Hello and welcome to the Brian Grant Foundation Wellness Webcast. I'm Amy LaValle, your Parkinson's Community Liaison and host. Today we're talking about the basics of Parkinson's medications. For many of us, our days start and end with a pill box, and many times we have questions about our medications and routine, but don't always have the chance to ask, or if you're like me, forget to ask. Well, today that changes. We're going to get expert information on the basics of these prescriptions. Today's webcast is going to be an open dialogue between me and Shannon. I invite you to ask questions in the chat box below, and I'll do my best to get to them throughout the program. Just as a note, we will be discussing the general Parkinson's prescriptions meds. We will not be going into supplements. So if you have any questions about those, I invite you to talk to your doctor. Now, I would like to welcome Shannon Anderson, the Associate Director of Clinical Care for Movement Disorder Program and a Physician Associate at OHSU, and our presenter today. Welcome, Shannon.
Hi, thanks for having
So,
me.
thank you. So we're going to be talking about the basics of Parkinson's medication. So why don't you start by giving us a general overview of these medications and their classifications?
Absolutely. There's so many medications and it can be really difficult to keep them all straight. If you would allow me, I think it's best to kind of look at everything from a picture. I have a picture that we use in a lot of our presentations. A little disclosure, this picture is a little bit dated, but it really is the best picture to kind of get everything kind of organized. As a lot of folks with Parkinson's know, this story is really the story of dopamine. We're going to talk a lot about dopamine. So, I'm just going to share this picture with you all. So, let's get this going. How does this look, Amy? Does this pop up? Excellent. Okay. So, let me orient you a little bit. Let's get this laser pointer. Okay. So let me orient you to what we're looking at here. So here we have these dopamine receptors. So Parkinson's disease is a story of dopamine. So when we have Parkinson's disease, what happens is we are losing dopamine over time. So why is dopamine important? So we have dopamine, we have cells in our nervous system, and the way that cells talk to each other is via dopamine. So the way that this cell talks to this cell is through dopamine. So this cell is going to release dopamine over to this cell, and it receives it through these receptors. So the whole story of medications is how do we help support dopamine in the system? So what do? We give dopamine in one way, shape, or form. So, how do we get dopamine? Why don't we just give dopamine to a bunch of patients with Parkinson's disease? Well, we have this thing in our body called the blood-brain barrier. And this helps us to protect us from a lot of like toxins in the world, a lot of poisons in the world, a lot of things. This blood-brain barrier is really protective. We want to keep things outside of our brain. Our brain is really a really high important organ, obviously. And so this keeps this protective barrier here. And so how do we get dopamine into our brain? Well, we have this thing called levodopa. And so we give levodopa to patients. Levodopa gets into our system. It can cross the blood-brain barrier. And when it crosses the blood-brain barrier, it turns into dopamine. And so that's fantastic. That's why levodopa is sort of this great medication that we give to patients because guess what? It turns into dopamine once it gets into our brain. So losing dopamine over time, let's give dopamine back. So that's why a lot of patients with Parkinson's disease end up taking levodopa. Well, why don't we just give levodopa all by itself? Well, what happens is if it breaks down in our circulation, so in other words, if it does not cross into the brain, it breaks down in our circulation or in our body. What's the big side effect? We puke. We get really upset tummies. We get nauseous. We throw up all over the place. Why does that happen? Well, there is this terrible protein called DDC. It breaks down levodopa. So, how do we block that? We give a medicine called carbidopa. Carbidopa blocks this DDC and it helps all of this levodopa cross over. So carbidopa is sort of like the truck. It's like the key that helps the levodopa cross into the brain. So that's why we give carbidopa and levodopa together to help that levodopa get into the brain. What's the ratio of carbidopa levodopa? What's the dose? It's 1:4. And so that's why the dose that you see of that carbidopa levodopa tends to be 25/100. And so that's sort of that magic kind of potion or that kind of magic ratio. So one fun fact is a lot of you sort of know there's two different names of drugs. We call it carbidopa levodopa, or the brand name or the manufacturer name is Sin-A-Met. Some of you might have taken Latin when you were back in school. Sin means without, emet or emesis means puking. So when we developed carbidopa levodopa, we found that we stopped puking all the time. So that's why we call it Sin-A-Met. We don't puke as much when we do carbidopa plus levodopa. So that is why we've got that levodopa going into our brain, transitioning into dopamine. That's why this drug, which was discovered all the way back in the 1960s, continues to be really the main medication we use and why we have to add carbidopa to it. There's a lot of other drugs that we use, a lot of other kind of friends or big players around the system. So what are some of the other classes of medications? Another group are what are called the COMT or a COMT inhibitors. You'll see them listed here and you'll see them listed here. What do those do? Well, these medications help levodopa stay in the system a little bit longer. So they help, levodopa gets broken down by another group of enzymes. And so what do these do? They block enzymes that break down levodopa. So if we block the breakdown, then levodopa lasts longer. How much longer? Only about 30 to 60 minutes. So not a super long time, but still can be pretty meaningful for people. So that's what the COMT inhibitors do. What about this group of medications? These are called MAOB inhibitors. What do these do? Well, this helps prevent an enzyme that breaks down dopamine. So what does this do? This is a group of enzymes that break down dopamine. So this helps keep dopamine in the system. Well, that sounds pretty exciting. If we keep dopamine in the system longer, that's something that we really want to happen. And so there's some controversy. Does this have what's called a neuroprotective effect? Does it make our disease, does it slow down our disease? And the answer is probably not. It probably doesn't have that neuroprotective effect, but we still probably want our patients to be on this medication. Sometimes it's the first medication that we start our patients on. Doesn't tend to have a lot of big impact on our symptoms of Parkinson's. Sometimes it does. Not a major impact on the symptoms like levodopa does, but that's where our MAOB inhibitors come into play. Then we have our dopamine agonists. This is another group of medicines. They work on our dopamine receptors. They sort of, agonists kind of are like, they kind of help as opposed to antagonists that hinder. So agonists, I kind of think of the agonists, they work on the receptors. They sort of, in a layman's terms, they sort of think of them like they make the receptors think like there's dopamine there when it's not really dopamine. There's a lot of different type of receptors. There's 5 different dopamine receptors. Agonists work on 2 of the receptors. And so oftentimes they have less of the side effects that levodopa has. And a lot of times they have different side effects that levodopa has. And then lastly, there's amantadine. And amantadine is kind of a funny medication. It helps with some of the Parkinson's symptoms. It also helps with some of the side effects of levodopa. And we really don't know how amantadine works, but it's kind of a great medication. It has some side effects to it too, but that's another tool in our toolbox. So that's just kind of an overview of all of the classes of medication, just to kind of set the stage for us.
All right, so now on to our dialogue. We're running this a little bit different today, everybody. We're just going to be chatting. So Shannon, how do doctors decide what classification of medication to start with?
Yeah, there's a lot of different ways that we decide. A lot of it has to do with the stage of disease that a patient's in. A lot of it has to do with the symptoms a patient is presenting with, and a lot of it has to do with the side effect profile. So everybody's different. I know you've probably said it on previous webinars, you've probably all heard it, but if you've met one person with Parkinson's disease, you've met one person with Parkinson's disease, and medications are no different. There are general rules and flavors. So if a certain person is a certain age, we might think about starting one class of medications versus another. But really, it is a very nuanced conversation. And so one piece of advice that I would say is that if your provider starts you on one and starts your friend on another, it is not a personal attack on you, or it's not that they probably didn't think of something. And if you have a question about why they didn't start you on a certain medication, ask why they thought of that certain one for you and not a certain another medication for another.
Thank you. Is there any reason to delay medication, particularly if you are young onset and recently diagnosed?
I love this question so much. We get this all the time. The answer, we used to think the answer was yes. And truthfully, the answer is no. So we in the medical community really have contributed to a lot of misinformation around this question. So we used to think that if you delayed starting the medication, that you would delay the onset of side effects, or the onset of side effects related to the disease. That solidly has been disproven. So no matter when you start the medication, that has no relation to when you're going to develop side effects. So you really do want to start the medication when it is most useful to improving your quality of life. Now, when you come in for your appointments, there is a mixture of, reporting what's going on in your daily life. So things like, we'll ask you questions about how long does it take to do certain tasks, buttoning buttons, getting your credit card out of your wallet, putting jewelry in, getting toothpaste on a toothbrush, using your utensils, how intrusive is your tremor, getting your arms into sleeves, those kinds of things. And then we'll have you do a physical exam, which may or may not feel like it's super useful. We'll have you do this, we'll have you do this, which nobody does in real life, but it truly is useful. And we'll put those two pieces of information together, and there should be a dialogue on whether or not you want to start medication. There is a degree of use it or lose it, right? So part of medication and wanting to start medication is wanting to keep your movements big and wanting to keep those movements fluid. And so some of it is trying to get that brain to see nice, big, fluid movements. Mm-hmm. So I often do hear patients say, yes, I still can get my arms into sleeves. And then their care partner says, but it takes them twice as long, right? And so we might say, well, let's try and start medication to see if we can't shorten that time, because we want your brain to remember the shortened time, the bigger time, because we want to keep that imprint in there longer. We don't want the smaller imprint to be in there.
Yeah, I when I first started my cinema, I didn't realize how much I was overcompensating for that loss of movement, like just doing dishes or changing a diaper. It was like, wow, this
Yeah.
is so much easier. Yeah, it's why if you still have that quality of life, just live it, enjoy it.
Absolutely. I kind of liken it to asthmatics. They don't realize that they're breathing through that straw, and then you give them an inhaler, and they're like, "Oh, this is what it feels like to breathe like
Exactly.
through those big lungs." And to a credit to all of you with Parkinson's disease, I don't think you all realize how well y'all are acclimating to those movements because y'all figure things out, and that is how we live successfully with Parkinson's diseases. We find all of these workarounds. That's what our OTs teach us to do and our PTs teach us to do.
Yeah.
So let's have our medications to help us out with that too. And that's the other kind of, part of that equation.
So talking about carbidopa, levodopa, you just mentioned the reason we have carbidopa, which I didn't realize. So if somebody is still getting really nauseous on that, is there an opportunity to increase the carbidopa, or is it just as always seems like it's 25, 100?
Yeah, for most people, it's that 1-to-4 ratio. But for other people, that's not quite enough. That carbidopa truck is not big enough to cross over that blood-brain barrier, and we need to increase that ratio. And so there is another medication called lodocin, which is just carbidopa by itself. And so we can prescribe extra carbidopa, make
Mhm.
that truck bigger to get that across
Okay.
that blood-brain barrier. So that is definitely something that we can do. Oftentimes that nausea happens when we first start someone
Mhm.
on carbidopa, levodopa, and as that carbidopa builds up in that system, that nausea improves over
Mhm.
time. That's usually something we see in the beginning couple of weeks and then resolves with time. And then as we go up on that dose over the months to years with having Parkinson's disease, it's not something that comes back as we go
Yeah.
up on the dose. There are other treatments that we have for nausea for people. There are still people who have just really
Yeah.
persistent nausea or throwing up, and there are other treatments, other kind of gut motility treatments or other kind of fancier things that we need to do because we do see people who just do not tolerate this medication at all.
Okay. So talking about this medication again, there seem to be so many different forms. You want to go in and elaborate on that a bit?
Totally. And again, kind of one of the things that we do is, because dopamine is the money shot with this disease, there are so many different forms of carbidopa, levodopa, or levodopa in general. There's short acting, there's long acting, there's blends of the short acting, long acting, and they all work in different ways. So there's kind of traditional Cinemet. IR means immediate release. And what that means is that it gets into your system and then there's this burst of release into your system. So that's the immediate release. Typically, that's when we first give that, we give it to folks 3 times a day. Then there's the CR or ER, those are extended release or continuous release. When those first came out, we hoped that that would last all day long. Didn't work out super well. I lovingly call the CR crappy release because it doesn't work super well. So the reason why is because when it gets into your system, it doesn't start to release into your system until it wants to. It's kind of like a toddler. It just does what it wants when it wants. And then it gets into your system, and the amount that gets into your system is variable. So the immediate release is much more reliable. The continuous release is variable. And for us to rely on a medication for your mobility, we don't want variable, we want reliable. So when we use that continuous release, the times when we use it is sometimes we'll use it before bedtime is a time when we might use that. Or for those folks who do have a lot of trouble with, like that burst, like people who do have a lot of side effects with that big burst or something like that. Then we moved forward and the drug companies developed a more reliable version of the continuous release. So Rytari is the newest version, where it's kind of a mixture of continuous and immediate release put together. And so that's kind of the best, newest version of an immediate and a continuous release put together. There's also an inhaled version of levodopa, like an inhaler version. That's more used for when our medication just drops out from us and we need like a burst of levodopa, like a rescue medication. And then there's the newer versions, the surgical versions. So there's the infusion versions, the pump version, and then the new subcutaneous version, the under the skin versions of levodopa.
What is the maximum dose of levodopa?
Love this question. We get this question all the time. So there is a maximum dose if you are to go and look it up online. And this is my plug for never looking things up online. So don't do it. Don't read the package inserts. Don't look it up online. Talk to your providers about that. The reason why is because the journey that this medication takes is so variable. So, like if we talk about the pill version, the pill's got to go into your mouth, down into your stomach, and you're going to lose some soldiers in the stomach. And then it's got to get absorbed in your small intestine. You're going to lose some soldiers there. Then it's got to get into your bloodstream. You're going to lose some soldiers there. Then it's got to get past the blood-brain barrier. You're going to lose a ton of soldiers there. And then it's got to communicate with your receptors. So by the time it gets there, you've lost, like you've only got your like most excellent troops. And everybody's going to have a different amount. So of those 100 milligrams that you actually took, you're only going to get a small percentage of that. And Amy, you might get 50%, but your friend might get 70%, right? And then maybe on Monday you got 50%, but on Tuesday you got 60%. And so that's why the maximum dose story is sort of a hypothetical one. The maximum dose really has to do with side effects and not dose. And so when you come to a movement disorder provider, we're really looking at toxicity less to do with the number of pills or milligrams you're taking per day and really how your body is reacting to it.
So just listening to you to describe the route the cinematic or the carbidopa levodopa is taking and how much we lose along the way, why don't we have a more efficient way? Why isn't there a sublingual or just inject it into your brain?
Totally. So the sublingual still has, so there is actually a sublingual. It still
Yeah.
has to go down into your tummy and into the blood
Okay.
and across the brain.
Mhm.
So we do have that. And sometimes in the hospital, they'll give the sublingual thinking it'll get absorbed under the tongue, but it still has to take that journey.
Mhm.
Um, the subcutaneous pump that just came out, it's called Vialev or Vialev. I'm not sure. We're still learning how the pronunciation of it. It's so brand new, like a month or two out. Um, what that does is that skips the whole gut part of the story and goes right into the blood. It still has to go from the blood to the blood-brain barrier and into the brain. So it skipped a pretty big part of the story, which is great. But still, it's getting there. And we have looked at a direct to the brain injection. There have been some studies that OHSU's been involved in. Um, and there have been some promising results, but not as direct to prime time as we would have liked those results to be. Those have all sort of stalled at the level of clinical trial, and the punchline is that unfortunately, despite that figure that I showed you, Parkinson's is more complicated
Yeah. Yeah.
than it is than just dousing your brains with a bunch of dopamine is basically the easiest way to explain it.
And talking about the complications of this disease, we just had somebody ask about the Cinemet. Does it help with precision of movement or is it tremor? I guess that's like, does it affect all the movement systems and non-motor symptoms, or is it just targeted for one area?
I love that question. It really helps with a lot of the symptoms of Parkinson's
Hmm.
disease. So when we're starting someone on Cinemet, um, this is a great question because I really do think it's important for you as the patient to know why is your provider starting you on the medication and what symptoms should you be looking for in terms of your area of improvement. So, um, we do want it to help with the precision of movement. We do want it to help with the speed and the fluidity of your movement. When it comes to tremor specifically, it's a little flip of the coin. So for some patients, it does help with their tremor, and for some patients, it doesn't. Which is
Hmm.
not to say that it helps 50% of the time. It just means that sometimes it helps and sometimes it doesn't. And if it doesn't work for your tremor, we don't tend to chase it in terms of,
Okay.
helping with the tremor or not. For some of the non-motor symptoms, Cinemet can help. Levodopa can help with some of those non-motor symptoms. So mood and anxiety and depression, I do have some patients who do report that those symptoms do improve or worsen when they are low on their dopamine. So if you think about dopamine, that's that joy, feeling great, I did it, pat on the back. That's what that, neurotransmitter does. And when you are low on that, that makes sense that the opposite of those feelings would kind of pop up. And so it can, contribute to some of those symptoms as well.
Got one or two more questions before we move on to the next segment. Can you talk about the patch a bit? Because how is that rooted and how efficient is the patch?
So there's a dopamine agonist patch, the retigotine patch, and it's similar to some of the other dopamine agonists. There's pramipexole or Mirapex and Ropinirole or Requip, and they work in a pretty similar way. One of the other sort of side effects of the patch is just the skin site problems, and we get around that by rotating the location of the patch. One of the nice things about the patch is that y'all tend to have pill fatigue, and so having a patch to not have that pill fatigue is a really nice option for people, and it has that nice constant delivery as opposed to the up and down fluctuations of taking multiple pills throughout the day. And so the patch can be a really nice option for some people. The problem with the patch tends to be that sometimes we need to try the pill options first from an insurance perspective before we're allowed to try the patch. And so the other one thing of the patch is that sometimes it can be hard to um, be a little bit nuanced. We have to pick the dose and stick with the dose. And so with the pills, sometimes it's nice to kind of be a little nuanced with those. And some people like that option as opposed to the patch. There's that one dose for 24 hours. And so if we have a nice stable dose, the patch can be really good for that, as opposed to if we're still in the process of finding and fine tuning the dose. We like to have the pills available to us.
Okay. And one last question for this section is the somebody just said like the inhaled version sounds fantastic. What is the downside of that?
Great question. So there's these little pellets that you put in an inhaler, kind of like an asthma inhaler. And so you put the pellets and then you crush them and then inhale the pellets. The side effect of them is that the pellets get inhaled back into the back of the throat. And I hear from a lot of patients that that is a really uncomfortable sensation and they cough as a result.
Okay.
So sometimes when you're really low on your dopamine, getting it all set up is tough from a mobility perspective, and the cough and coughing it out, they don't get a great dose. And so for people who don't have the cough or have someone help them to set the device up, it can be a good option for them. But the cough has been a really big rate limiting
Hmm.
step for actually getting
Okay.
the dose into them.
All right. I know some more questions are coming in, and I will try to get back to them a little bit later, but we are going to move on to more of the day-to-day management of the Parkinson's medications. Um, and this is a one talking about the nuances of pills. You're often told, oh, you can cut the pill in half.
Mm,
I don't know about everybody else out there, but my carbidopa levodopa crumbles. So it's kind of a
totally.
silly question, but how do you deal with those pills that, you cut it and then you just kind of end up with some dust or big chunks missing or
Totally. Yeah. So, I mean, that's one of the things that leads to whether or not you're going to get troops into where they need to be is
Mhm.
whether or not you can even get them into you in the first place. And so, there's a lot of different device manufacturers for these pills. And so, if you have one manufacturer where the pills just crumble into dust, you can ask your pharmacist for a different manufacturer and see if there is a better manufacturer that has a more sturdy pill that will hold up to that pill cutter.
okay. And somebody just asked about a pill called Divi, which I guess is made to be cut.
It is so Divi, it's sort of I actually have a fork in front of me. So it looks like this. And so the pill comes like this. And so it's in quarters. It's pretty expensive, but it is meant to actually be quartered
Okay.
off. And it is carbidopa levodopa that can be quartered.
Oh, that's pretty awesome. So talking about pill management schedules, what do you recommend for keeping track of your schedule?
Absolutely. So there's a lot of different strategies and this would be my biggest plug would be for an occupational therapist. And so an occupational therapist would be the person who could work with you specifically on what works best for you. And the other plug that I have is the patient support groups. You all have the best ideas. And I have patients who come in and show me their systems, and I am just like baffled by what you all come up with. Um, I will say though that I think that there are too many alarms in everybody's world. And I think that if I had one piece of advice, it would be to cut back on alarms. It would be don't set an alarm for every single dose because I know I have one alarm in my life and I ignore that alarm and I don't have Parkinson's disease. So maybe to think through what dose do you most need that alarm for and think about an alarm for that dose because you don't need an alarm for every single dose and really think through an alarm is really that it's alarming you to something really important. And so really maybe pull back on the alarms. We don't want Parkinson's to be alarming. I want it to just be something in the background of your life. I don't want it to alert you every 2 hours. Hey, you have Parkinson's disease. Stop everything and drop everything. If there is a different way to remind you of taking your medications that is a little less alerting, I would be in favor of that.
Yeah, I started off with the alarm on my wrist, my smartwatch buzzing, and it just got so annoying that I had to turn it off. I was like,
It really is.
buzzing every 4 hours. I can't
Yeah,
handle this.
I agree with that.
So just on that topic a bit, should we be more consistent with the time we're taking the medication or the time between our doses? Because if I'm sleeping good on the weekend, I don't want to wake up at, 6:30 because I'm actually sleeping. So what do you recommend?
Yeah, this is a really person to person specific answer. So I'm definitely going to preface with that. This is also a provider specific
Okay.
answer. So that's my other kind of preface to the answer to this question. I do think that at certain phases of your disease, there are times when you do need to be very on top of taking your medications very on time. And there are times when your body lets you be late or miss a dose. And I think that if you are in a phase where your body is okay with that, embrace that. Because as the disease progresses, there will be times when you do need to be really on top of taking your medications on time. Bodies do better when you when it is predictable. And also, it is easier for us to make thoughtful decisions if there is a pattern. There is so much, we already talked about kind of the nuance of
Oh no, it looks like we may have froze. There we go.
that medication, take that journey. Okay, good. And if we can control certain things and minimize the factors as much as we can, sorry, it's looking like my internet's a little bit unstable. Is everything okay on your end, Amy?
You're back to live. Yeah.
Beautiful. Okay. If we can kind of minimize those factors as much as we can, then we try and minimize them. Having said that, if you're late, it's okay. It's really life happens, and we totally understand that life happens. And so you do the best you can, and you live your life the best you can.
When you are, when did you ask your doctor to start a new medication, or when is it time to seek a new change?
Yeah. I think that it is if you're noticing something going on with your body, talk to your doctor, reach out, ask the question. This is your first time with Parkinson's disease. You don't have to know if this means, this is normal progression, we should make a change, we should add a medication, we should adjust a dose. You don't have to know what we're going to do with that information. You're just the people who inform us of what's going on with your body. And so give us the information and let us make those decisions. I think that oftentimes, patients feel like they sort of need to know the answer before asking the question. Now's the time to make a medication change. Therefore, now's the time to make the appointment, or they'll wait until their 6-month appointment, or they think that there's some magic timeline. If you're noticing something and you're not sure, please reach out and ask, especially, or if your care partner or a friend is noticing something and they're wondering. If you think there's a new medication that's out and you're wondering how that may or may not, or when that may or may not be a part of your routine, please send a note and sort of say, can we talk about this at our next visit? Or do you think that we should schedule maybe a virtual visit ahead of time if it might not even need a physical exam? We'd love to hear from you about those
Yeah.
kinds of questions.
So that brings me to my next question is when you are starting a new medication, how should you prepare for that?
Great question. I think that the $1 million question is, what's your goal? What is the tangible goal? This is all quality of life. And what are we looking to improve? What is the thing that we're looking to change? Again, nobody does this, right, in daily life. And so what is it that we're looking to, what's the goal here? And so for you or for somebody else, it might be, I'm looking to, play pickleball, or I'm looking to improve like the fluidity of my movement, or I'm noticing that the speed at which I'm doing a certain task is, or I've noticed my mood or my sleep quality, or, what is it that, how is my Parkinson's impacting my daily life? And then work backwards from there. It might not be a medication that does it. It might not be a dopamine medication that does it, or it might be a combination, right? A little bit of a medication and a little bit of therapy. And so, really, what is it? How does my Parkinson's negatively impact me in this moment? And then we can kind of work backwards from there, as opposed to, I heard about this pill, I'd like to add it to my regimen and my routine.
What if you don't like your doctor's suggestion? Um, how do you, what do you do?
Allowed, first of all, totally allowed. Um, I would say figure out why. What is it? Is it that you're not understanding, that y'all aren't communicating appropriately, not appropriately, but you're not communicating with one another. You're not understanding why it was suggested, or the reason. So in other words, you are looking for something more natural or more therapeutic, whereas they're suggesting a pill and you're not speaking kind of one to one with one another, or maybe they're recommending something more natural and you're wanting a pill. And so I think that it's okay to disagree. And I think that sort of identifying what that is and why, and trying to speak that same language. And it can be very difficult because you do want to be in alignment and agreement with that person in terms of your treatment plan and trying to find that common ground. You don't always have to speak necessarily with that prescriber. So oftentimes there's other members of that team. There can be a nurse, there can be an APP, so nurse practitioner, a PA. There could be like a physical therapist or an occupational therapist who works with that provider too. And so maybe hearing it from a different person who's also on that doctor's team, it's the same message, but just from a different person on that team might help to communicate that same message in a different way.
Okay. Well, thank you. I would like to move on to our next session, and then I've been collecting some of these questions that we'll get back to in a bit. But I'm going to call them kind of medication scenario questions. Um, so, given the complexity of medication schedules, what are some tips to making sure I'm taking the right dose right on time? And then somebody asked, what if alarms don't work for you? So,
Oh,
nice
yeah.
big question for you to answer.
There's a lot of, yeah. So, okay. So say the first part of the question one more time.
So, having a complex medical schedule, what are some tips on making sure you're taking the right dose at the right time?
Yeah. So there's a lot of different, again, I would, another plug for our occupational therapist, because they really can help us sort of identify what are our barriers, kind of what, when we have that very difficult medication schedule, what are some of the barriers for why it's difficult for us to be consistent with that schedule, and also how can we help simplify it. The other thing is that if we have a difficult schedule, sometimes the occupational therapist can go back to that prescriber and say, are we sure that this is the best schedule for the patient? Because
Mhm.
sometimes us as the prescribers think, oh, this is totally it. And we're kind of back to your previous question. We didn't really think through the patient and the success that it's going to translate to the
Mhm.
patient. And we said, okay, we're going to do one tablet here and 1.5 tablets here. And then 3.5 hours later, we're going to do a tab and a quarter and then entacapone with every other dose. And what we come up with these bizarro schedules. And then it's the social worker who comes in and says, there's no way this patient can be successful with that. That might be medically what you think, but from a practical perspective, that's not helpful. So let's go back to the drawing board and we can help work with the family on streamlining and simplifying it from that perspective. So that might be one way to do it. Um, there are different, worksheets that we can work with, having that social worker help with a care partner or care team, and having someone, identifying someone who can help us setting things up at the beginning of the week in terms of pill boxes, can help. There's a lot of really fancy things, high tech things online. There's a lot of low tech things online. And so, again, I've seen kind of all sorts of things that patients have come up with all over the place. And so, really taking advantage of that healthcare team, OTs, social work, et
Mhm.
cetera.
Well, and I'll even put in a plug for the pharmacist. I mean, this was a couple
Yeah,
years ago, so I don't know if they do this anymore, but I had a neighbor and she would do bubble packs of the medications. So she would
yeah,
make little packets of like, morning dose, mid dose, evening dose, and just do the organization for you.
absolutely.
So what about when you're traveling and you're experiencing a time change? How should you manage that? Do you stay on local time or adjust to new time?
Yeah. My recommendation is to, on the day you're traveling, stay with the time zone in the location that you're traveling from. So if you're on Pacific time, stay with that time zone. And then instead of going with the time, you stay with the hours. So let's say you take your medications every 4 hours. You would dose every 4 hours on the day that you travel. And then the next morning on when you arrive, you start that next day. If your first dose is at 6 a.m., you start at 6 a.m. the next morning, and then
Okay.
6 a.m., 10 a.m., etc. And so you just instantly kind of rip the band-aid and start that next morning.
And I would also recommend to those traveling to just take the first 2 days and just make them as nothing days so you can adjust.
Fantastic. Absolutely. Between the medications and
Yeah.
sleep, everything else, that's a fantastic idea.
What about over-the-counter medications? Are there any we should avoid, especially now that we're in the cold and flu season?
Yeah, many of the cough and cold medications, if you look on the back of the bottle, they just have this blanket. Be careful, don't take them if you are taking
Hmm.
Parkinson's medications. And the Parkinson medication that they are referring to, the class of medication that they're referring to, are the MALB inhibitors. Um, you want to, if you're taking the MALB inhibitors, you want to just send a quick message to your Parkinson prescriber or your pharmacist or whoever to just double check and make sure it's okay. The risk of interaction is exceedingly low. And so you definitely want to run it by us just to make sure. You obviously want to err on the side of caution. And certainly if you're taking other medications other than those, you're always welcome to ask your primary care or the pharmacist at, Walgreens or Safeway or whatever. But it's not a all Parkinson's medications concern or worry. It's really that one class of medicine. The worry is that if you take the medications, if they interact, that your blood pressure would get high. The
Hmm.
reason why it's exceedingly rare is the MAO inhibitors stay in the brain and the cough and cold medicines stay in the blood. And so they don't tend to interact with one another. And that's why the risk is very, very low.
What about some contraindicated prescription meds, particularly Haldol?
That's a great question. So there are some prescription medications, Haldol being one of them, that we can't take when we have Parkinson's disease. And
Okay.
and Haldol is in a class of medicines that blocks dopamine. So Haldol is in a class of medicine that's called an antipsychotic medicine. There are a couple of others that also block dopamine. And so that's why that's a no-no in Parkinson's disease. We don't want to be blocking your dopamine. There are other medicines in that group of medicines that are
Mhm.
okay to take in Parkinson's disease. Another group of medications that we want to be aware of that block dopamine is anti-nausea medicines. There is a group of anti-nausea medicines. A big one is called Reglan that also block dopamine. There's another nausea medicine called Zofran that is okay to make. So there's options in some of these groups that you can't take and options that you can take. The Parkinson Foundation has an aware and care kit that I hope that everybody's aware of. You can go on their website and usually they have a list, a card that says, I have Parkinson's disease. Here's a group of medicines that I cannot take. So if you have to go to the hospital or the ER,
Mhm.
hard for you to speak for yourself, there's a list of a lot of these medicines that under no circumstance can you take. And these are medicines that, like, if you did have to go into the ER, that the ER provider, if they wanted to give you, then they would say, nope, nope, we'll try the other ones that are okay to take.
I saw somebody had posted online a while ago that you should put down as being allergic to Haldol. Is that a recommendation, or just should you refer to this card and just hope that the in an emergency situation they will understand this?
You certainly could. It would be called an intolerance, as opposed
Okay.
to true allergy.
Hmm.
Um, it's certainly an option to you. It's pretty rare, but I would never say no to
Okay.
that question.
So, and we're talking about emergencies. What else should we carry to be prepared for an emergency? whether it's either a health emergency or like a natural disaster emergency.
Yeah, so a lot of these medications are like if you were going to a hospital, for example, some of the newer medications. So hospitals carry, like if you were admitted to the hospital,
Hmm.
hospitals have medications in their own local pharmacies. So carbidopa, levodopa, or Maripex, or all of these medications. The newer medications aren't always at the hospital. So if you had an operation, for example, or if you were, gosh, if you had to go to the emergency room for whatever reason, um, you would potentially have those medications at that hospital. You might not have the newer medications at that hospital. So what you would do is you would bring your own medications. What the hospital would do then is they would take a look at your medications and then give you your own medications. Now, letter of the law, you can't give yourself your own medications while you're a hospital patient, but the team would check in your own. So if you were on some of these newer drugs, they would check in your own and dose yourself.
Okay.
The other thing I would say for hospital admission, and I think a lot of people on this call probably know this, is that it's very difficult to get our medications on time when we're at a hospital. So there's a couple of things here. We as the prescribing providers, we try and do our best when we're writing our prescriptions to say what time we should take. So when I write a prescription, I want to write down take your pills at 6 a.m. and 10 a.m. and et cetera, instead of just take it 3 times a day because the math is a little bit different. Um, but when you check in, you want to make sure that that all lines up. And you might ask for, when you check in, for an extra dose to go in to it. So an extra Parkinson's
Mm.
medicine, we call it a PRN, which means I get to ask for it whenever I want Parkinson's dose. You have PRN pain medicine or PRN nausea medicines. You might ask for a PRN Parkinson medicine, which means I ask for my Parkinson med because sometimes our Parkinson symptoms get worse when we're in the hospital, in addition to your extra
Yeah.
Parkinson. So your regularly scheduled Parkinson's medicines.
Since we're on these medications long term, are there any concerns about how it affects our other systems, our guts, our lungs, etc.?
Broadly, no. Nope. You're
Okay.
these are long-term meds and you're going to be on them for a long period of time. And there's no studies that show it has a negative impact on your GI system or your respiratory system or any of those other systems. So no, they're okay to take for here on
Okay.
out. Mhm.
When starting a new medication, should you expect your doctor to check in on you, or should you be proactive and give them the heads up?
It would always be proactive, but
Okay.
that's our job is to,
Hmm.
and we're the prescriber, to make sure that we're checking in, that we're monitoring. I think we all have experience with some providers who have different styles and who do that with different frequency, or have members of the team do it. So, we might have our nurse do it or our pharmacist do it, or just have a different style. And I think that's part of the conversation when you're starting. What does that look like? How do you want me to communicate with you, or how are you going to communicate with me? And so that could be part of the dialogue when you are starting a medication. What do you want that to look like with your prescribing provider?
And if there is something going on with your medications, when should you be concerned and seek immediate help? And then in that scenario, who should you see and what do you say?
Yeah, if you're concerned, you don't have to decide if it's good, bad, or not. You're the patient. And so if you think it's a worrisome thing, ask for help. Um, the neurologist office, you always can ask for help, especially since we're the prescribing provider. But we don't always have, someone urgently answering the phone call. And so if you really do feel like it's an emergency or urgency or needing to be act on quickly, going to either primary care or an urgent care, they are very trained to deal with urgencies, no matter what it is, even if it is Parkinson's related or related to your medications. And so you don't have to know who or where or how or what's going on. If you think it's an urgency, reach out to somebody, anybody, and get help quickly.
So back to some of the questions we've had coming in. With the pump, if somebody has needed that extra carbidopa, would you also need that for the pump?
The Duopa pump or the subcutaneous or any of the above.
Um, I don't know. So let's say maybe subcutaneous right now.
So the subcutaneous is so brand new that we don't know. We
The,
don't have
okay,
experience. So I'll answer
then the
that.
duopa.
Yeah, so the Duopa pump, we haven't needed to give additional carbidopa.
Mhm.
And so that hasn't been an issue. It's been skipping so the Duopa pump skips the stomach completely and goes directly into the small intestine. And so we've not noticed that the nausea has been an issue for those patients. And so we've not had to give additional carbidopa. So we also have very few patients on it. And so it could
Okay.
be a product of just not having enough people, but that's not been something we've noticed.
What about the dopamine agonist side effects? I know that is kind of a scary thing for a lot of people. So, what can you say about that?
It's a very real concern, and it's definitely something we've seen. It is something that we want to very much be thoughtful about the people we choose to start dopamine agonists on when we want to have a really careful conversation about the risks and benefits. So the side effects that you're alluding to are the risks of compulsive behaviors, impulsive behaviors, things like excessive shopping, excessive spending, risk-taking behaviors, pornography, sex, kind of all of these really risky, devastating type behaviors. These are things that can happen at low doses and can get worse over as that dose is escalating. And so really having a conversation with the patient and somebody who has eyes on them, whether it be a care partner or a thoughtful friend, and stopping that medication,
Okay.
if it's becoming risky. We have patients who are seeing compulsions on that aren't devastating. So I have had patients who work out more and it's not impeding or impacting their lives.
Mhm.
Patients who write their memoirs and it's lovely and we just watch it and monitor it. And so there is a sliding scale to it, but it's definitely a concern. And the dopamine agonists do have a role in managing symptoms. They can be really helpful. They help with a lot of the mood aspects of Parkinson's
Mhm.
disease, sometimes better than some of our antidepressants. And so you really want to be thoughtful about the use, the dose, and a monitoring plan.
With Cinemet, does it affect your dreams or cause insomnia in any way?
That's a great question. So it can impact dreams. It In terms of insomnia, I have had some patients say that it causes insomnia. I mostly have patients say that it causes sleepiness. So it will
Okay.
cause daytime sleepiness. Some people call it the on yawn, where they take their dose and as it's kicking in, they'll start yawning a lot or even start to really fall asleep. I have other patients though that as it's starting to kick in, because they go from that akinetic rigid state to a
Mhm.
much more limber loose state, they kind of feel more energized. And so it really kind of depends on the person.
And do you see a difference with that sleepiness between the Cinemet and the Rytari, for example?
So in the Rotari, all of those same side effects,
Mhm.
daytime sleepiness, on yawn, the Rotari, this is totally anecdotal. I have seen that last dose of the night cause insomnia, and I have no reason why. And so sometimes for some people, I will give them regular Cinemet as their last dose. And I don't know why, something to do with the way they're metabolizing it. That's not true for everybody, but when I switch
Okay.
people to Rotari, sometimes they say that.
Well, Shannon, we're like up against the hour, so I just have a few things that I wanted to end on with kind of the future of medication. Do you have any insight into something in the future, medicine or devices coming down the pipeline we should be excited about?
So I get questions all the time about the class of medications. They're called GLP-1. They're the anti-diabetes medications that we
Mhm.
have our eyes on. They're showing a lot of promise in animal studies, and they're starting to come to human studies. So we have our eyes on that. So I think that that would be something that we're definitely looking into. And there's also some, they're called anti-synuclein antibodies. So synuclein is the thing that builds up in our brain. And we're looking at that. There's some studies that are in phase 2 that are going to phase 3 that we have our eyes on. So we're excited about those too.
Great. And my last question for you. Any advice to our audience or something you wish patients would ask you?
I wish they would ask the question that they feel uncomfortable asking their provider. So be brave. It's your bodies. This is a quality of life therapy. So please be brave and ask the thing that you feel really uncomfortable. You guys drive the truck. And so please advocate for yourselves.
Thank you so much. Man, this hour just flew by, Shannon. You were fantastic. And thank you for providing all of this excellent practical information. I hope everybody who joined us today got some good info that they'll be able to walk away with and implement to their daily lives. I'm sorry that we weren't able to get to all the questions. We had some great ones coming in. But in the end, if you have any questions, please feel free to reach out to your doctor, the nurses, the support staff. I hope everybody has an excellent day. Also, if these programs are doing great things for you and you have information or feedback, please fill out our survey or drop us an email and let us know how we're doing. Thank you, Shannon, again, and everybody have a wonderful day.
Thanks, Amy.